Well, good morning, everyone. Hoping that those down in breakfast will join us soon. So we have a small but dedicated audience. So welcome. I'm Chris Forsmark from the University of Florida.
And I'm Subira Roy from the University of Miami.
And the session today is pain and pancreatitis. How do we assess it and how do we treat it? I will give you an update. There were only 3 lectures this morning, not 4. The lecture by Dr. Bielman, which is the 3rd lecture, won't happen today. So we'll start with the first lecture. It's by Asbjørn Drews from Aalborg University Hospital. Asbjørn is speaking to us virtually, but he will join us for questions at the end. He's certainly been a world leader in understanding the pain in chronic pancreatitis and how to assess it. And his title is Pathogenesis and Management of Pain in Acute and Chronic Pancreatitis.
Good morning, ladies and gentlemen. My name is Asbjørn Drews from Denmark. And first of all, I want to thank the organizers for inviting me to this beautiful meeting. And I'm so sorry I can't be here in person. US government still have many restrictions towards Europeans traveling to Miami. I have changed the title a bit in the interest of time, but I'll come back to that. First of all, a few descriptions, and then I'll move to the pathogenesis of pain, starting with acute pancreatitis, where, as you all know, we have inflammation, we have edema, obstruction, different tissue factors that results in sensitization of the neurons and therefore an increased afferent barrage to the central nervous system. This is processed as pain intensity and localization in the cortical structures, while the limbic system is mainly responsible for the affective and cognitive responses to the brain. We also have a descending inhibitory system arising from the brain system that is able to gate the incoming stimulation, and this feedback system makes the pain tolerable. At the more molecular level, you can see the different receptors, and time doesn't allow me to go into that in detail. I'll just stress that you should notice that everything is more or less going on in the periphery. If we move to the pathogens of pain in chronic pancreatitis, is a different story. You have some cases obstruction, tissue hypertension, extrapancreatic factors that results in sensitivity, but normally the peripheral nerves are not sensitized. What means something is the ongoing neuropathy due to the destruction of the nerves by the fibroinflammatory process. And this neuropathy gives spontaneous firing of the neurons that bombards the spinal cord, again resulting in sensitization of the spinal cord, and therefore an increased upstream activity to the brain, where pain is processed in different structures, but due to neuroplasticity and sensitization, this becomes abnormal, and finally we have a lack of normal inhibition. That was a very short story of the pain pathogenesis in chronic pancreatitis, and at the molecular level, again, you can see that most changes are going on in the central nervous system, whereas the peripheral nervous system is normally not abnormal unless there is a neuropathy with increased firing of the neurons. So, sorry, after this short introduction, I'll move on to pain management of first acute pancreatitis. And we have different guidelines, but they're not very helpful because, for example, in this APEC guideline, pain management was not mentioned at all. But this is also the case in the UK Working Party and the AGA guidelines from 2018. They simply offered no recommendation for pain management. But what do we have? Well, we have a lot of analgesics in our armamentarium, and this shows where they have their main mechanism of action. Normally we use a WHO analgesic ladder. We increase the dosages and the different medications depending on the pain intensity. And for the weak analgesics, we have a lot of studies. And again, time doesn't allow me to go into these. I'll just show you a recent meta-analysis that is not yet published, but we looked into 12 papers, including more than 500 patients with acute pancreatitis and 6 treatment modalities. And the main conclusions were that epidural administration is actually the most effective analgesic modality. NSAIDs were as good as opioids for the first 24 hours. But a real meta-analysis could not be done because of the heterogeneity in the pain relief reporting. And what we have as pancreatologists to do in the future is to develop a good questionnaire for pain assessment in acute pancreatitis. Moving on to the strong analgesics, again, we do not have much guidelines in acute pancreatitis. On the other hand, a recent paper here in Lancet from the Dutch group mentioned that opioids could decrease the need for supplementary analgesics. We do know something about factors associated with opioid use. This is from California. More than 4,000 patients from 14 medical centers were analyzed, and they concluded that 80% received opioids during the initial stage of the acute pancreatitis, and the factors important for their use were age, sex, race or culture, and of course disease severity and pain score, but also comorbidity and alcohol use. My colleagues often ask me whether or not I'm afraid of dependency, and I would stress here that this is not the case. And this is supported by Ackman and co-workers that studied about 235 opioid naive patients with acute pancreatitis, and they concluded that no daily opioid use was seen after discharge unless patients had chronic pancreatitis, and on-demand use was only seen in patients with current acute pancreatitis. So you shouldn't be afraid of opioid use in the short run. If you look into what we have for first aids, what we have is recommendations for acute abdominal pain management, and I don't think it matters much whether they have acute pancreatitis or abdominal pain in general. What Falk and co-workers did was that they analyzed 84 papers, and one of the main conclusions were that opioids did not negatively affect neither diagnosis nor treatment. They came up with this flow chart where they basically recommended that patients with pain less than 4 on the 0 to 10 scale should have simple analgesics and anti-inflammatory drugs such as NSAIDs, whereas if they had more than 4 on the scale, they recommended to use opioids with increasing dose depending on the intensity. Of course, the reason we need to treat the patients appropriately is that we had to do that. We cannot leave them with acute severe pain without doing anything. Furthermore, we are afraid of central sensitization. I cannot go into details with the basic mechanisms for that with the time I have available. I just want to pay attention to this paper we wrote a couple of years ago, which is actually the most cited paper in European Journal of Pain dealing with development of sensitization. And what we are afraid of is that pain attacks repeatedly or long-lasting pain can result in sensitization of the central neurons, and then pain becomes present even though the acute pancreatitis disappears. And this is what we're afraid of, to develop chronic pain because of malpractice and insufficient acute pain management. Well, if conventional analgesics do not work, do we have a plan B? I shortly mentioned before that epidural anesthetics is something we can use with local opioids and also anticonvulsants, of course. And this study, which was retrospective, looked into those 46 patients out of about 1,000 who had epidural anesthesia, and they had much better pain control, but also reduced mortality. And the reason is likely that they had better perfusion of the tissues and better gut barrier function. But of course, it has to be studied in details later on, but there is a lot of work to do. And I think this is an option we should really try to look into. Moving on to pain management of chronic pancreatitis, it's another story. Here, pain management becomes multimodal. We cannot rely on analgesics anymore. We have a lot of different treatment possibilities. Again, in the interest of time, I cannot go into all of those, but start with the basic procedures. And I know there is a lecture about surgery later on, so I'll only deal with endoscopy and ESWL. If you look into observational study, the efficacy of endoscopic treatment seems to be pretty good, with a response in between 60 and 85% of the patients that at least have less pain. The problem is that we don't not really use which patients to treat. And we have a problem that we normally treat those patients with a CT scan like you see this here, where there is severe duct obstruction and a stone, but no pain. Whereas in other patients have a normal appearing duct system and severe pain. So it has been documented in many studies here that there doesn't seem to be any relationship between the imaging and the pain intensity. And what we need is really to do better randomized controlled trials, and we don't have any of those. But we're actually doing a study at the moment in Hyderabad in India, where we, together with our Indian friends, look into the efficacy of ESWL and ERCP in patients with chronic pancreatitis pain, and we randomize them to either active or passive treatment. And we have now enrolled, I think, 45 patients despite the pandemic, and we expect to have some results already next year. But before we have that, we cannot say for sure much about the efficacy of endoscopy and which patients to treat. Again, we have some controversies between invasive treatments and also whether or not they are effective and what is the effect of sham and so on. I can recommend you to read this paper we published a couple of years ago in GOT, but I would state that no matter what you do and no matter which invasive treatment, most patients still receive analgesics. So in the second part of my talk, I will speak about analgesics, and I'll leave the neuromodulation procedures and the antioxidants and so on to another talk where I had more time. So in the rest of my talk, I'll speak only about analgesic treatments in chronic pancreatitis. So what do we have in our armamentarium? Like for acute pancreatitis, this slide shows you where the different analgesics have their main mechanism of action. And again, I cannot dig into the different mechanisms. I'll just answer the question whether or not these analgesics are effective. And this is very easy to answer because it is yes, they are all effective. If you look into this slide, for example, it shows that the number needed to treat is about 1 to 2 in order to reduce pain intensity by about 50%. So what's the problem? The problem is the side effects. We have so many side effects to analgesics and all other kinds of medication. And I want you to pay attention to this paper here, where they describe the side effects to all medications, not only analgesics. And they concluded that side effects on the small and the large intestine accounted for about 20 to 40% of the drug-induced side effects in total. So this is a huge problem for all kinds of drugs, and especially for analgesics, because, I mean, analgesics, they work on the brain, they interfere with the normal neural signaling, but they're not specific to the pain processing. And therefore, analgesics typically have a lot of central nervous system induced side effects, but you should be aware that the enteric nervous system has as many neurons as the brain. This is about 5 billion. It has library information, memory functions, everything. And therefore, the effects on the gut is as troublesome as the effects, as the side effects you see on the brain. Typically, NSAIDs have side effects, but also tricyclics, NSNIs, and especially opioids with opioid-induced constipation, and so on. So the balance between effects and side effects is the main, say, target for our future studies and treatments. And actually, we wrote a recent paper about that, which was called Pharmacological Management of Chronic Pain, How to Deal with the Catch-22 Situation. No matter what, the title is rather catchy. I can recommend you to read that if you want to know more about this balance, but I have to go back to basic in the interest of time. Then we could say, what is the recommendation for treatment in chronic pancreatitis? Well, we do not have many good RCTs out there. Most are about the gabapentinoids. There are some in opioids, but we are not happy for opioid in the long-term use in chronic pancreatitis. So you could say that the really only recommendation we could have is to give patients pregabalin. The problem is that this drug has many side effects in patients and can also be addictive. Sorry. So, but of course we cannot rely on a recommendation that only tells us that we can use gabapentinoids in selected patients, because there are many analgesics out there. And in the ideal world, we have to do good RCTs for all kinds of analgesics in pancreatic pain. And I know that will never happen, but in the ideal world, but I could ask you then the question, if true, would we all be happy then? Well, of course, we would not be, because all pancreatitis are not the same. There are different degrees of fibrosis. Some have neuropathy, some does not. What about calcifications? What does that mean? Some have pseudocysts and others have small bacterial overgrowth. So what you should do is to do RCTs, good RCTs for all these different subtypes in all different kinds of analgesics, and that'll never happen. But the good news, ladies and gentlemen, is that the difference between individuals is bigger than between diseases. In other words, there are maybe much more similarities between these patients with chronic pancreatitis and the other patients with low back pain as there is between different pancreatitis patients, because disease doesn't mean much. What means something is duration of pain, degree of central sensitization, psychiatric comorbidity, co-medication, social factors, and so on. In other words, when chronification is present, pain is pain. So you can use the results from other pain studies in, for example, low back pain and other diseases, at least to some degree, in patients with chronic pancreatitis, so we don't have to use to make all these RCTs. So a universal recommendation for analgesics can be this one, as we published for pancreas cancer in the International Guidelines 2018, where you can see the different treatment modalities we have out here, examples and different comments, but still you have to individualize your treatment because patients are not the same. Some respond to some analgesics, others to others, but most importantly, some have severe side effects to some analgesics, others have severe side effects to others. So this is very important to stress. We do have some first aids some guidelines, as for example, in this paper we published a couple of years ago, the International Guidelines for Management of Pain in Chronic Pancreatitis, where we also came up with some flow charts. I know this is very busy and I'll not walk you through it, just tell you that we had some help out there. So now, are we done yet? No, I want to stress something about organization. The main problems we have in pancreatic pain management is actually who takes this responsibility. I would say that if I look at it throughout the world, I can see that the specialist is very often rather invisible. He leaves treatment with analgesics that I should say are among the most difficult medications to use to the junior doctors or to the GPs. The specialist may refer to the pain clinic, but still you should be aware that there are many reasons among the most difficult medications to use to the junior doctors or to the GPs. The specialist may refer to the pain clinic, but still you should be aware that there are many reasons for pain in chronic pancreatitis, and some of them, like peptic ulcer, ischemia, drug-induced bowel dysfunction, surgical complications, can only be identified and treated by the pancreatologist. And therefore, no matter what, the specialist has to be very visible here, and although he'll refer the patients to other specialties, you must still take the responsibility. And that was all from Denmark. Thank you very much for your attention.
We're going to take questions at the end.
Okay, the next speaker is Dr. Vijay Singh. Dr. Singh is an associate professor of medicine and director of pancreatology at the Johns Hopkins University of Medicine. He's the current vice chair of the pancreatic disorder section of the AGA Institute Council. And his talk today is, can quantitative sensory testing diagnose central sensitization in the clinic?
And Dr. Singh is now a full professor, by the way.
Thank you. Thank you for the kind introduction. I'd like to thank the APA for this opportunity to present this lecture today. And I'd also like to mention that this lecture was originally to be given by Dr. Anna Phillips, who is a collaborator, colleague, and friend, but unfortunately she couldn't attend the meeting this year. I have a few disclosures, but none are relevant to the content of this lecture. So we have really three objectives that we're going to focus on. The first is to define central sensitization. The second is to describe quantitative sensory testing, and more specifically, pancreatic quantitative sensory testing, and then review some of the data supporting pancreatic quantitative sensory testing as a pain phenotyping instrument in chronic pancreatitis. I think it's important to note and always kind of come back to the very basic definition of pain. Pain is a symptom, but it's important to note that it is in and of itself a complex disorder. And all pain, regardless of what causes the pain, has four determinants. The first is nociception. The second is perception, which involves the pain's processing centers of the brain. The third is suffering, which involves the emotion, the emotional, cognitive, mood areas of the brain. And last but not least are pain behaviors, which include things like groaning and grimacing and curling up in a fetal position when one is in pain. And what I want to really highlight as well is the fact that the pain processing centers of the brain are exactly the same centers as the pain suffering. So in fact, there is a strong interplay between where pain is processed and how we feel about it from an emotional, cognitive, and affective standpoint. And this is precisely why simply looking at the intensity of chronic pain is the wrong metric, because we know that over time, it really has very little to do with the extent or severity of tissue damage, but really and even goes beyond nociception, but goes more towards the pain matrix and the regions of the brain that are involved in emotion and reward. And over time, we kind of move away from nociception and we go more towards these emotional and psychosocial factors. So another important principle is that chronic, not acute, chronic pain can result in central sensitization. And if you look at the list of conditions that are associated with chronic pain, it's important to note that there's a couple that gastroenterologists commonly encounter in clinical practice. Of course, the one that has brought us all to this meeting is chronic pancreatitis. But we also have another very closely aligned visceral hypersensitivity condition known as irritable bowel syndrome. And of course, some of us who may even see patients with upper GI tract disorders, certainly non-cardiac chest pain, and last but not least, postoperative chronic pain, which can exist in 5 to 10% of patients even undergoing common routine abdominal surgical procedures. So what is central sensitization? So, I wanted to keep this as as concise a definition as I could come up with. Central sensitization is a nociceptive phenomenon where ongoing peripheral sensory afferent barrage from the pancreas into the central nervous system results in the progressive amplification of the pain response that can persist and generalize independent of the source. It can affect the brain centers involved in emotion, cognition, and affect, and can reduce the ability of the brain to control that pain, which is something known as central pain modulation. There are many sequelae of central sensitization. So this in and of itself is not such a simple phenomenon. All these things, including decreased central pain modulation, vagal dysfunction, sympathetic afferent coupling, as well as hypoactivity of the hypothalamus pituitary adrenal axis, can all occur as a consequence of central sensitization. How is this relevant to us clinically? Really comes down to these sort of 8 features. So the real clinical indicators of central sensitization are depression, anxiety, hyperalgesia, allodynia, stress-related pain exacerbations, fatigue, poor sleep, and autonomic dysfunction. Many of you note that a lot of our patients with chronic pain and chronic pancreatitis have POTS, and we always wonder why. So all of these things are really manifestations of central sensitization that we commonly encounter in clinical practice, and we have to recognize that all of this connects back to the central disorder that we're trying to treat. What is hyperalgesia and allodynia are really the clinical correlates of sensitization. And what is hyperalgesia? Hyperalgesia is something that it's a stimulus that causes pain normally, but in somebody who's sensitized, it causes even more intense pain. Allodynia is a stimulus that doesn't cause pain in normal individuals, but in somebody who's sensitized, that can actually result in pain. And now, this slide was shown by Dr. Yadav yesterday, where he showed that in the cohort of patients that we've been following as part of our PQST consortium, that the presence of clinical depression and anxiety are quite common in all of the pain phenotypes and are associated also with quality of life. And more recently, the NAPS2 consortium has nicely shown that there is a genetic susceptibility to depression. The genetic susceptibility to depression and anxiety is associated with pain phenotypes, including the constant and severe pain phenotypes. And this is interesting because you not only have a clinical predisposition, a genetic predisposition to depression and anxiety associated with pain, but also a clinical one. And that's why patients with depression and anxiety are so common, or chronic pancreatitis patients commonly have depression and anxiety. So what is quantitative sensory testing? These are diagnostic tests that have been developed to assess the somatosensory function. They measure the detection threshold of calibrated sensory stimuli that are related to distinct neuroanatomic pathways with discrete nerve fiber populations. These tests are psychophysical, thereby they require cooperation of the patient. The sensory stimulus is objective, but the response from the patient is subjective. An abnormal result may result in signal dysfunction along the sensory pathway. And historically, quantitative sensory testing has been used primarily in the evaluation of neurologic disorders. These are some of the tools of the trade. They include instruments such as pinprick devices, as well as on the right-hand side, you can see there's devices that can deliver electrical and thermal stimulation. And in the bottom right-hand corner, you can see the device that we use to perform tests to assess central pain modulation. Pancreatic QST, more specifically, is a new and simplified testing protocol that has been tailored specifically for pain assessment in chronic pancreatitis. This was developed and validated in collaboration with the PQST Consortium, which was 3 centers in 2017, and we have now expanded to 6 since the earlier part of 2020. This utilizes the convergence of both visceral and somatic afferent nerves in the spinal cord to facilitate surface testing of the pancreatic viscerotome, which is otherwise known as the T10 dermatome. And then there are tests that evaluate conditioned pain modulation, which is a clinically measurable form of descending inhibition. So the T10 dermatome and the pancreas synapse at the same level in the spinal cord, and that's why that's the area that we focus on when we perform, or that's a part of the abdomen that we focus on when we perform a history and physical examination. So you'll have painful stimuli that go from the pancreas back to the level of the spinal cord, and that pain is, because of that viscerosomatic convergence, the T10 dermatome can be tested to assess whether or not there's pancreatic pain. I'm not going to go into the details of the PQST protocol. I'm just going to describe the 3 individual tests. One is temporal summation, and this is measured on the forearm and the abdomen. And this tries to test the principle that repeated stimulus at the same intensity can cause buildup of pain over time, making it more painful with each stimulation. So you use a pinprick stimulator to perform this test. So you do a test on the forearm and on the T10 region of the abdomen, and just kind of showing you how this looks. So by actually applying the pinprick device in a repetitive motion over at 10 pinpricks, you then can ask the patient how they feel in terms of a visual analog pain rating scale. The second test is looking at pressure detection and tolerance. This is measured in 5 different locations over the surface of the body: the clavicle, abdomen, back, pelvis, and knee. The device that's used is called a pressure algometer. And what you're really looking at is the pressure pain detection threshold, as well as the pressure pain tolerance threshold. And these are the regions of the body that are tested. And really, you're trying to test areas that correlate to pancreatic pain, and then other areas to see if, in fact, the pain is more widespread, because that would indicate that somebody actually has sensitization. So this is the way this is performed. You apply the algometer, and you actually get a pressure readout. And when the patient can't tolerate it anymore, then you stop and you look at your reading, and then that gives you another measure of this of pressure detection. The last test is known as the conditioned pain modulation, where you put your, this is to detect whether or not there's a problem with central pain modulation. The hand is exposed to ice water for 2 minutes, and the patient's discomfort is rated every 10 seconds on a scale of 1 to 10. And once the hand is removed, because the patient can't tolerate it, then a score of 10 is assigned for that time point. And both pressure pain tolerance is measured before and after. Yet another way, this is probably the most sensitive test among the PQST battery for assessing sensitization or widespread hyperalgesia. So these 3 different tests can differentiate patients into 3 distinct pain phenotypes by pancreatic quantitative sensory testing. And I won't go into the individual measurements to get these 3 different pain phenotypes, but we had done this in normal control patients to determine the different pain phenotypes that you can see there on the right-hand side: normal, segmental, and widespread. A simple way to think about that is that segmental is basically the equivalent of peripheral sensitization, and somebody with widespread sensitization or widespread hyperalgesia, I'm sorry, has both peripheral and central sensitization. We then also evaluated this in a cohort of about 180 patients with chronic pancreatitis. And as you can see, about 51% of patients tested to be normal. 28% of patients had segmental sensitization, and 21% had widespread sensitization. We also conducted a pilot study to see if this could help us determine which patients are likely to respond to interventional therapy. So this was a very small study, only 30 patients, and all these patients had pancreatic quantitative sensory testing performed, and then they underwent endoscopic management. And the idea was to then have them come back 6 months later to determine whether or not these pain phenotypes were associated with treatment response. And as you can see, the patients with the no hyperalgesia and those patients with segmental hyperalgesia had better pain responses than those patients who had widespread hyperalgesia. So we are actually in the process of doing a prospective randomized an observational prospective study where we will enroll a lot more patients to determine whether or not these different pain phenotypes hold up. One other place where this has been used to help us from a clinical standpoint is Dr. Drews and Olson had conducted a randomized controlled trial evaluating Pregabalin versus placebo for the treatment of pain in patients with chronic pancreatitis. This was published 10 years ago, and what they found was over 3 weeks of therapy, Pregabalin actually reduced the average daily pain score by 36% compared to 24% in the placebo patients, and most patients were on opioid analgesics. But more importantly, they found that quantitative sensory testing actually predicted which patients were going to respond. This was done by an earlier generation of quantitative sensory testing, but you can see the responders actually had they had higher levels of segmental hyperalgesia compared to the non-responders. My colleague, Dr. Foggy, who's here in the audience, actually presented this study, and I'm not going to go into a lot of detail about this, but I think this is important because this also highlights the complex nature of pain as a symptom, because we evaluated 3 factors here to determine what best correlated with the patient-reported outcome of pain and quality of life. So we looked at pancreatic duct obstruction, we looked at hyperalgesia as measured by pancreatic quantitative sensory testing, and we also looked at psychological distress. And as you can see here, the one that had the most impact was actually psychological distress, whereas the hyperalgesia was actually limited to an impact on quality of life. Certainly, if we had more patients, maybe we could have found a significant result with hyperalgesia, even across the pain metrics here. But what's also interesting is if you go down, you look at the R squared, that's the amount of variance that's explained by the model. You can see under the BPI pain interference score, the R squared was actually 34%. That means there's still a lot of other factors out there that probably influence the pain response in patients with chronic pancreatitis. So I'm just going to finish up with the very last final answer to the question that we were tasked with is, can quantitative sensory testing diagnose central sensitization in the clinic? I think since QST is dependent on subjective evaluation of the sensory experience, it does not meet the strict definition of objective biomarker. Because remember, at the end of the day, we will never have a biomarker for pain. We will only have a biomarker for nociception. They're 2 different things. But it serves as a simple and feasible proxy of the pain system that in conjunction with other tests, including psychological assessments, can help us phenotype pain and potentially allow for more tailored treatments based on these phenotypes. Sorry for going over.
Is Dr. Phil Hart. He's an associate professor of medicine in the division of gastroenterology, hepatology, and nutrition at the Ohio State University Wexner Medical Center. He's also a counselor for the International Association of Pancreatology and is an associate editor for pancreatology. His talk today is Considerations for Clinical Trials on Pain in Chronic Pancreatitis. Dr. Hart.
Thank you for the introduction. Good morning, everybody. I'd like to thank the meeting organizers and even more so thank you, who I would consider to be the faithful remnant of the APA, who made it through 3 late nights, a couple fire alarms, and about 75 interruptions from people's phones going off when they were trying to open up the app for the meeting here. So I've been asked to speak on clinical trials on pain and chronic pancreatitis. I think the first 2 speakers really helped to set the stage for the need for this topic. These are my disclosures. So in the next 10 minutes, I have a few brief objectives that I'd like to cover. First, to review the status, the current clinical landscape of studies in chronic pancreatitis. Second, to introduce 4 key challenges to enable us to plan and successfully conduct clinical trials in this space. And then lastly, to discuss what I view as some opportunities and next steps to advance the field. So the fundamental question that underlies this whole session actually is why even study pain and chronic pancreatitis? And the resounding and hopefully clear answer for us in the room is that this is important to our patients. These data were taken from a meeting that was held with the FDA that was sponsored by the National Pancreas Foundation related to drug development for pancreatitis. And sort of the resounding responses from participants was that pain is important. So the vast majority of patients experienced pain. When they did have the symptom present, it was considered or ranked as the most burdensome symptom. And when asked what the most important need for study of in clinical trials, they indicated better pain control. So there's a clear need for this, but what are we doing, and what is going on today? These are some figures that I abstracted from clinicaltrials.gov last week. You can see there's a little over 40 clinical studies that are actively open and recruiting patients with chronic pancreatitis internationally. For frame of reference, there's about 40 studies in acute pancreatitis, but in inflammatory bowel disease, over 500. So there's a huge gap and opportunity for us to do more. Of the studies that are posted, about a third of these indicate that pain was the primary endpoint. But when you do the breakdown related to study design, you can see that almost half of these studies are observational studies. And not that there are not things that we can learn about pain from observational studies, but that is certainly not going to move interventional decisions forward, as Dr. Drews indicated earlier. So what are some challenges to conduct clinical trials on pain and chronic pancreatitis? I think there's a long list of challenges. I'm just going to go through 4 this morning. The first relates to study design, and there are a number of challenges that come as a result of not having clear consensus guidelines and or standardization of a number of key elements that are necessary to perform clinical trials. As a consequence of this, when an investigator is set with the task of designing a study protocol, in many regards, you're having to make a lot of unique decisions for that study without an industry standard per se. Even though you may have really thought out your eligibility criteria and other items for the study, you're still subject to lots of criticism, whether that be from a grant reviewer or from a reviewer of the study itself. The second is that for those who have participated in clinical trials, even to do an open label clinical trial is very time consuming. And as a consequence, it ends up being very expensive. All of the costs related to the regulatory oversight and monitoring, the study personnel, research team, et cetera. And so there's a huge need for additional funding in this space. Third, which Dr. Drews, I think, highlighted this challenge very well, relates to our study population. So to begin with, chronic pancreatitis is a low prevalence disease. So then if we go further and are interested in studying a subgroup of patients with chronic pancreatitis, for example, those with pain, then we've shrunken the number of patients who may be eligible for participation. If we try to improve the rigor of the study by increasing the rigor of eligibility criteria, for example, such that you're looking for patients with a specific pain phenotype or a specific pain intensity, if you want them to be opioid naive or opioid experienced, all of these decisions which enhance the rigor of the clinical trial quickly shrink the recruitment pool, so that becomes challenging. The second consideration is this perception of poor patient compliance. And I think that this is a myth which I hope that everyone in the room would agree with me regarding. But unfortunately, this perception remains in the community, and you know, it's not uncommon to get feedback from grant reviews that this is not a suitable patient population to study because of this myth of poor compliance. I think that's something that we as a community need to resist and fight for on behalf of our patients. And I think that the thing that we can do as investigators, though, is to craft our studies and trials in a manner that really works to enhance and reduce participant burden. And then lastly, one of the key challenges as it relates to studying pain in chronic pancreatitis is just the challenges related to pain. That, as the speakers already have introduced, the pathophysiology is extraordinarily complex. And in chronic pancreatitis with pain, we recognize that there's a discordance between the pain severity, pain interference, and the morphologic features of disease. So there's additional work needed to be done there. So a number of challenges. Is there any room for hope? I think so. So I'd like to highlight a few what I consider opportunities, and then also introduce some potential next steps. So I like this quote here, the pessimist sees difficulty in every opportunity, while the optimist sees the opportunity in every difficulty. And for people who may be like me as a born pessimist, I think that this is instructive and just a situation where we need to learn optimism. So there are a number of key conversations to identify and address knowledge gaps in the field. And the NIDDK has been really helpful at sponsoring a series of workshops related to drug development and the delivery pipeline for pancreatitis, a recent workshop related to pancreatic pain. And then I'd also like to just make a plug as a save the date for this coming July. The NIDDK is sponsoring a workshop specifically related to the topic of clinical trials in pancreatitis. Additional work is being done, as highlighted by Dr. Drews and Dr. Singh, related to approaching and gaining more of a consensus related to how we assess pain. Different assessment tools are being developed. Also, multi-center consortia are maturing. They're growing in number as well as longevity. I've introduced a few here, the CPDPC, which is a collaboration in the United States, NIH funded, the Dutch Pancreatitis Study Group, and then also the PQST Consortium, which is now an international organization. The other thing that gives hope is that trials being successfully completed is starting to happen more and more. We're starting to see some momentum. And I say successful in that these are studies that successfully complete enrollment, but they're also showing some initial early effects, which is encouraging. And then lastly, I'd like to thank and just call out that the patient advocacy groups such as National Pancreas Foundation are continuing to promote the partnerships with the key stakeholders, patients, investigators, pharma, FDA. And so this has really been helpful. So what are some potential next steps? I think that, and I think the previous speakers really made this point really clear, that we need additional understanding of pain in the context of chronic pancreatitis, including refining the endpoints to be used for assessment in these clinical trials. Next, to continue to develop and implement best practices for clinical trials in patients with chronic pancreatitis, which will require consensus agreement on how to do so. And then lastly, to leverage some of the existing networks and collaborations to further expand the research pipeline, meaning both the number of trials, but also the breadth and nature of those trials. So in summary, I hope that it's clear that there is a need for additional trials on pain and chronic pancreatitis to address our patients' needs. There are a number of general and specific challenges to conducting these trials, but I also think that there's a lot of room for hope that we'll be able to see and realize improvements in the chronic pancreatitis clinical trials landscape, even in the near horizon. With that, I'd like to acknowledge our team at Ohio State, and I'm over time, so I won't yield anything back, but yeah.
And if we could get Asbjorn back on as well. Hello?
I hope you can hear me.
Yes.
Hi,
Just have to turn you up just a little bit. So 3 terrific talks, and please come forward for questions.
This is a great session, and
really have a lot of respect for all the people that are involved in this. This is a very important topic. One comment I wanted to make was that at the Ohio State, with the help of George Papachristou, who has worked with me to see every acute pancreatitis as soon as possible after admission, I've been impressed by people that are in horrible pain, have high doses of morphine or Demerol, and I recognize that they are under fluid resuscitated. They haven't got any fluids, and by just giving them fluids, their pain goes away, and it's probably visceral ischemia. And so the first thing to do before giving them analgesics is to fluid resuscitate them, and many times the pain will markedly resolve or be reduced. So I think that's just an important comment to make.
Thanks, David.
And actually, our group actually published a paper looking at factors associated with opioid use in patients with acute pancreatitis, and we found that hemoconcentration was actually a predictor of increased opioid requirement. So it stands to reason that if you gave those patients potentially more fluid and dropped their hemoconcentration or resolved it, that their pain would be better and they would use less opioid.
I have a question for Asbjorn.
Can I comment on that?
Okay.
It's just that, I mean, I thank you very much for this very important comment. I mean, it doesn't matter whether it's acute pancreatitis or chronic pancreatitis, you always have to look into other factors and use analgesics and other pain treatment modalities as a last resource, because there are very often other things that you can actually discover if you just use your sound clinical knowledge.
Asbjorn, I had a question for you, and maybe it ties into Phil Hart's talk, and that is in situations of any chronic pain where the pain has become centrally sensitized, you know, low back pain or whatever, and you initiate a therapy, how long does the therapy have to, what's the duration of therapy that you need to continue before you can make a judgment about whether it's been effective or not? And I was sort of thinking, as we consider designing trials for chronic pancreatitis pain, if it's centrally sensitized and your agent is working on central mechanisms, is it evident within, I mean, is it months of therapy, weeks of therapy? How long do you have to treat before you know whether it's actually working?
Well, this is a really good question, and this is also a very difficult question. First of all, some medications have an immediate effect, such as, for example, opioids, whereas others, such as NRIs or opioid combinations like tapentadol that we use a lot in Europe, takes about 2 to 3 weeks before they have their main analgesic efficacy. On the other hand, what I see the main problem, as I also said in my talk, with treatment is balance between analgesic efficacy on the one hand and side effects on the other. And therefore you very often have to balance for, I would say, weeks before you can actually find the right dose for the right patient. And I should also say that if you, for example, play around with some analgesic for weeks for some patients, in the same patient, if you use another analgesic, you may adjust the dose in a few days. So it is very variable and it's really demanding for the clinician.
A question for Dr. Vikas Singh. Do you see a correlation between inflammatory status, central sensitization, and the perception of nociception? Because in animal models, most of these pain receptors, nociceptive receptors, have to be sensitized by an inflammatory response.
That's an interesting question. I mean, where we typically study central sensitization in the pancreatic world is in chronic pancreatitis. And what's curious is most of these patients have a lot of fibrosis, but there's not a lot of chronic inflammation when you look at their glands from a histopathologic perspective. So I think the injury that's occurred in the peripheral afferent barrage has probably occurred earlier, so that by the time you're seeing the patient, you know, in a lot of ways, the central mechanisms are probably more predominant in terms of the pain description and response.
Good question. Obviously, there's pain, but the patients also have nausea and inability to eat. What's the panel's thought on the approach of sometimes putting in a feeding tube for nutrition as well as pain relief specifically in the setting of chronic pancreatitis, not acute. And I mean, where are we with that in terms of studies and looking at that as a at least temporizing measure? We often do that.
That there are studies actually that have tried to bypass the pancreas with a nasojejunal tube in order not to stimulate the pancreas. And these are old studies and they are mainly case-based, but they are actually promising. So if you use the tubes to avoid stimulation of the pancreatic juice and squeezing, so to say, you may improve pain in some patients. But I mean, it's very important to get the right feeding. I mean, feeding itself and gain weight will also help against the pain, even though we do not have any solid evidence.
What I'd like to add to that is I've been using Pregabalin to treat chronic pancreatitis pain for about 4 or 5 years now. So I have a pretty reasonable experience in using this, and I certainly have to publish this data, but I've never had to use any augmented feeding arrangement for most patients, because if I can put them on Pregabalin, they start to respond. A lot of that gets better, because remember, the inability to eat in these patients is probably not a motility problem. It's probably a reflection of sensitization, because it's maladaptive to not be able to eat from a human evolutionary perspective, or if you think of it that way. So if you can calm the pain down, often I find that they can go back to eating and you don't necessarily need enteral feeding tubes.
Go ahead, Jill.
Jill Smith, Georgetown University. First of all, I'd like to know how someone who's not in your consortium can collaborate with you. One of you threw up your email really quick and it went off. Because I have an idea that I think would work. We've been studying a drug called Pregabalin, which is an old CCK receptor antagonist. And we just published a paper in 2 models of mouse models showing that it reverses fibrosis in chronic pancreatitis, reduces the liver enzymes and inflammation and ADM and all those things, which are good. And but I haven't been able to get people in the pancreas world excited about this. But I will tell you, the liver people are very excited because it reverses fibrosis. And we just finished an NIH trial in NASH patients and in cirrhosis patients with PK. So we know it's safe, we know the dose. I would love to be able to let somebody on the consortium or work with you, because we have an IND number, we have the drug manufactured, we have it analyzed, we know it's pure, and it would be great to be able to collaborate. And the other thing is that there's a lot of studies that show that Pregabalin decreases pain. And for some reason, it crosstalks with the chemokine receptors. And there's a lot of old studies that show that it decreases dependence with opioids, and it prevents people from having to escalate their opioid dose. So I think it would be a great drug to test because it's non-addicting and safe. And it'll also reduce the CCK and inflammation. So let us know how we can collaborate with you guys.
Jill, I will send your email to both Phil and Vikesh.
Yeah, happy to share an email. And anti-fibrotic agents have become of great interest. In fact, there's a company that just went public that's looking at anti-fibrosis to treat Parkinson's and potentially Alzheimer's. And they want to extend out to pancreatic and liver diseases as well. But they're actually not looking so much at pain in the pancreas. They're actually looking more to potentially improve.
Kill two birds with one stone, you know?
Yeah, but we may be able to improve exocrine function in diabetes as well. So,
thanks. One question.
Hi. I just wonder if the central sensitization can develop some compensatory mechanism over time to reduce the stimulus, and if it does, what is the mechanism for that? Maybe some reduction in the expression of receptors, or some decrease in the number of, some fibers. I don't know how it can work.
Are you saying that central sensitization actually decreases over time?
No decreasing. No, there is some tolerance. I don't know if it's okay
Tolerance.
to say this, that work, appropriate some compensatory mechanism that can reduce the central sensitization over time. I don't know if it's correct.
Yeah, maybe Dr. Drews knows the
Well, I'm not sure I understand the
thoughts on that.
question. I mean, the whole schisma between tolerance on the one hand and sensitization on the other doesn't seem really to be related. So I don't think that kind of tolerance can interfere with sensitization per se, if this is what you're asking about.
I think maybe a very brief question, Dave. We're at the end of our time.
This is for Dr. Drews. I've been actually pretty impressed with people with severe pain from chronic pancreatitis also have low back pain, they have migraines, they have post-surgical pain on your initial analysis. And I'm wondering if you use that type of information to start therapy with different medications than you would with somebody with only pancreatic pain.
Thanks for the question, Dave. Well, I would say no. I mean, you're absolutely right that many patients have a lot of different syndromes, so to say, that are related to central sensitization. But I would not target the medication according to symptom, but rather to degree of sensitization and to pathology in the pain system, as Dr. Singh elegantly showed you how we do that. And we actually use this PQST in order to design our treatment rather than looking into different diseases and disorders.
All right. 20-second question.
Yes, hi, I just have a quick question. I know like we're almost out of time. I mean, just like a quick curious. We're talking about a lot about perception and sensitization. Like, is there any difference, a significant difference between like a young population, aging population in terms of perception and sensitization to the pain in pancreatic cancer patients? Just a quick question.
Actually, our consortium is going to look at pancreatic quantitative sensory testing in patients with pancreatic cancer to determine whether the pain phenotypes that we've established in chronic pancreatitis look similar in the pancreatic cancer population. It's not really clear. One big problem in the pancreatic cancer population is a lot of patients are on opioids, and opioids can generate their own hyperalgesia. So we might find that a lot of all these patients may tilt a little bit more towards a sensitized phenotype as opposed to a normal or segmental one.
Well, thank you all for your attention. Thank you for the talks.
Bye.